Hello everyone and welcome. Thank you for joining for the NEHIC University program today on Meaningful Use Stage 2. This is Kate Berry, CEO of National eHealth Collaborative, or NEHIC. NEHIC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care, including providing education on health IT. Today we are pleased to welcome our distinguished speaker, Robert Anthony, from the Centers for Medicare and Medicaid Services. I'll introduce him in just a moment. Because we have had such overwhelming interest in today's program, we're going to offer the same session again next week on Tuesday, April 3rd at 4 o'clock Eastern. Next slide, please. First, I'd like to very briefly highlight a few of our upcoming NEHIC University programs. We do offer a wide variety of education, including Spotlight Learning Series on Health Information Exchange, Spotlight Learning Series on Consumer Engagement, Spotlight Learning Series on the Beacon Communities, Careers in Health IT, ONC Initiatives, and Trends in Health IT Innovation. Next slide, please. Later this week, NEHIC University will have a program on the recent proposed rule on standards and certification. This will take place on Friday, March 30th at noon Eastern. Our speaker will be Steve Posnack from ONC's Office of Policy and Planning. And Steve will present an overview of the proposed rule and respond to your questions. You can register for this program at the URL on your screen. Next slide, please. We'll have a series of webinars providing in-depth case studies of the Beacon communities. On Wednesday, April 11th, we'll have a program featuring the Western New York and Southern Michigan Beacons. And on Thursday, May 24th, we'll have a program on the Utah and San Diego Beacon communities. Next slide, please. You can download and print the slides from today's program at the URL on your screen. Next slide. And during today's program, please do submit your questions as they come to mind by entering them into the Q&A window on the right side of your screen. Now I'm very pleased to introduce our speaker for today. Robert Anthony is a health insurance specialist in the Office of eHealth Standards and Services at CMS. Robert works primarily on meaningful use policy for the Medicare and Medicaid EHR incentives programs. So after Robert's presentation, we will open it up for Q&A. So now we're going to transfer control of the slides over to Robert.
Thank you, Kate, and thank you, everybody. I'm going to get situated here very quickly. I'd like to thank the National eHealth Collaborative for hosting this. We are going to talk a little bit today about the Stage 2 Notice of Proposed Rulemaking. And we'll do a little bit of an overview of that. I'm with the Office of eHealth Standards and Services, which is the office within the Centers for Medicare and Medicaid Services that sort of acts as the steward for the program. And we're going to talk a little bit about what was published on March 7th. The proposed rule for Stage 2 of meaningful use. This is the second stage in our three-stage process for meaningful use that would go into effect in 2014. You can see here these links will give you a direct link to the CMS rule in the Federal Register so that you can review it there. There's also a direct link to the ONC rule on standards and certification that Steve Posnack is going to present on later. That is a companion rule with the CMS rule. It talks about the standards and certification capabilities that are used for certified technology that is for use with the Meaningful Use program. We are in the middle of a public comment period, which means although we'll be doing some Q&A later in the program, I will not be able to talk a whole lot about the intentions or other things that are not actually published in the proposed rule because we're restricted within the comment period about what we are saying. However, I would be able to tell you if certain things are addressed within the proposed rule, and certainly I can answer anything currently about the program and Stage 1. We do encourage people to make comments. The best place to make comments is through regulations.gov. That allows you to submit those electronically, and it allows us to sort them a little bit easier and faster so that we can respond to all of them. We do encourage you to comment on the rule and to comment not just on what you don't like, but also on what you do like. Very often the vocal minority holds sway on some of these, and so we always encourage people to say when they think a particular thing is working or a particular idea or proposal is good within that rule as well. So just a quick overview of what you will find in the Stage 2 proposed rule. Even though this is actually addresses Stage 2, we are looking at some minor changes to what you will see in Stage 1 of meaningful use, and we'll review some of that as we go forward. There is obviously Stage 2 of meaningful use, what the individual requirements for that would be, the objectives. There's a discussion of the new clinical quality measures. There are several new reporting mechanisms for clinical quality measures that are proposed in this. There is an outline of the appeals process, a detail about the Medicare payment and adjustments, as well as the hardship exceptions, and some minor Medicaid program changes. We're going to cover most of this today very quickly. There may not be a great deal of detail because of the time that we have, but there is a copy of these slides I know has gone out to everybody. This is part of a larger library deck that CMS has available on its website, www.cms.gov/EHR incentive programs. Make sure you put the S at the end of it. You'll find a lot of resources that are already about the EHR incentive programs, but you'll also find a larger library deck rather, that has hundred-some slides in it about the Stage 2 NPRM. So one of the things that's covered in the Stage 2 NPRM is the Secretary's proposal to delay Stage 2 meaningful use for a year. You can see that those of you who remember Stage 1, the final rule that we issued a table that was somewhat similar to this that showed the schedule of meaningful use. We are proposing a delay for Stage 2, but it really only applies to providers who attested in 2011. So typically, as you can see from this, the conception would be that your first year of meaningful use, which is going to be your first year under Medicare, or if you elect to participate in Medicaid, it'd be your second year after your adopt, implement, upgrade year. Your first year is going to be 90 days at Stage 1. Your second year is going to be a full year at Stage 1, and then you move into 2 years at Stage 2. No matter when you start meaningful use, that was sort of the conception of how you would start, always with Stage 1. 2 years at 1, 2 years at 2, 2 years at 3, and so on. We are proposing in the shaded area that folks who came in 2011 would receive an additional year of Stage 1 meaningful use. Partially, this is to provide providers a chance to implement new software that they're going to need for Stage 2, and partially it's to allow vendors to make some changes to software that they're going to need for these Stage 2 requirements and objectives as well. So those of you who are familiar with the Stage 1 structure for meaningful use, you're not going to see a huge amount that is different here. We do retain the core menu structure that we had in Stage 1. As you'll recall, there was a series of core objectives in Stage 1 that everybody would have to complete unless you qualified for an exclusion for them. Then there was a series of menu objectives that you would select from among those menu objectives what you would report on. We did try to keep the number of total objectives on which providers had to report relatively similar. Partially, this was done through eliminating some core objectives. We'll take a look at what those were. Partially, it was by collapsing some objectives. So we'll point out a couple of areas later on as we look into this where we took some multiple objectives and we sort of combined them into one objective where a number of things would be accomplished. So you can see here for Stage 2, we're looking at 17 core objectives and 5 menu objectives, of which eligible professionals would have to select 3 for a total of 20, 16 core, and 2 of 4 menu objectives for a total of 18 for hospitals. As you go through the following slides, you're going to see that what we've done is we've bolded where you're going to see changes in the various core or menu objectives. So this is what's changed essentially from Stage 1. For example, if we look at number 2, e-prescribing for more than 50%, actually I should apologize, this should be more than 65%. This is an older slide version and we've since caught this, but in the NPRM we actually proposed 65%. But the bolded area is what has actually changed from Stage 1. In this case it represents an increase from the 40% requirement for e-prescribing right now. That's just quick reference for you as we go through these. So as you look at this, you'll see that CPOE, we have indicated a threshold of 60% for stage 2. We are also proposing to add laboratory and radiology orders to this, whereas in stage 1 there was only medication orders. For the recording objectives, this is 3, 4, and 5, recording demographics, recording vital signs, and smoking status. We've moved from a 50% to an 80% threshold. Some folks may notice that what is missing in this list up front is the objectives for recording a problem list, maintaining an active problem list, maintaining an active medication list, and maintaining an active medication allergy list. We have collapsed those objectives into an objective that follows, which is providing a summary of care after transitions of care. You'll still need to maintain a number of those in order to meet that objective, but we have combined all of that into one objective. Number 6 represents where we've also combined an objective. For clinical decision support in stage 1, it is implementing 1 clinical decision support rule. We're moving to implementing 5 clinical decision support interventions that are based on clinical quality measures upon which you report. We do recognize that there are going to be eligible professionals for whom none of the clinical quality measures actually fit their scope of practice. Therefore, in those instances, you could base your 5 clinical decision support interventions on high priority conditions for your particular practice. We've also combined this with the drug-drug and drug allergy interaction checks. As you'll recall, in stage 1, that is currently a separate objective. We had a lot of confusion from people about whether their clinical decision support could be the drug-drug and drug allergy interaction checks in stage 1. You can't. Those are actually separate objectives and therefore would have separate measures. So in this case, we have combined those, and you have an objective which has 2 measures in it, the first for the clinical decision support and the second for implementing drug-drug and drug allergy checks for the duration of the reporting period. We move incorporating lab results from menu to core and raise the threshold on that to 55%. Generating patient lists and providing reminders for preventative or follow-up care for patients move from menu to core in stage 2. And then you're going to see in number 10, and I'll draw attention to this again in the following objective on summary of care, we've introduced, we're moving from the notion of providing an e-copy of health information or providing simple electronic access to the idea of providing online access to patients' health information. For more than 50% of patients, this is the ability to view their health information, download it, or transmit it online. We've also introduced another concept that you'll see again in transitions of care, which is a little bit of a departure from stage 1. There's a second measure to this particular objective where we require that 10% of patients actually access their health information online. This is a change from stage 1 where really nothing that a patient did or didn't do could interfere with a provider meaningful use. Whereas we're making patient participation an active component of meaningful use for stage 2, or at least we're proposing it for stage 2, and we discuss that we believe that providers are in a unique position to encourage patients to take an active role in their health care by accessing this information in that case. We have moved from providing office visit summaries that was a 3-day period to a 24-hour period. Providing education resources moves from menu to core. One of the new objectives, most of the new objectives that we are proposing have actually ended up in the menu for both EPs and hospitals, but one of the new objectives that we are proposing for the core for EPs is that more than 10% of patients send secure messages to the EP. Again, this is another instance of patient action being a requirement for meaningful use in the stage 2 proposal. The ability to do this type of secure messaging would actually be included within the certified EHR, so this isn't a new, or this isn't a functionality that you would have to go searching for outside of it. This is a functionality that will be built into the EHR. Medication reconciliation moves from core to, or from menu to core. Number 15 is an area that really represents sort of a robust change. Some folks may remember that in stage 1 we have the electronic exchange, or the test of electronic exchange of key clinical information, as one of the requirements, core objectives for eligible professionals and for eligible hospitals. We're moving towards a more robust health information exchange objective with number 15. We're providing a summary of care document after transitions of care, and this was an objective that was in stage 1, but it was an objective that really required a fairly limited amount of information: problem list, active medication list, medication allergy list, and diagnostic test lab results when those were available. Now we are requiring all of those fields in order to send that summary of care document, which means that providers will have to maintain problem lists and medication allergy lists. But we're also requiring a host of other information, and I would encourage people to take a look at the proposed rule, because there are, I think, 15 to 20 different fields that we're asking for. Some of it is demographic information, some of it is contact information, care plans when those are available, so on and so forth. So we've really turned this into a very robust health information exchange objective. There's also a second component to this, which is that 10% of those summary of care documents have to be sent electronically, and the requirement is that they have to be sent electronically to a different provider with a different EHR. And when we say different provider, in this instance, it is a different provider with a different organizational affiliation. So it's not somebody that you already have an organizational affiliation with. It can't be somebody within the same practice. It can't be somebody that you have an existing organizational relationship with. And it also has to be sent to somebody who's using a different EHR. And in this instance, we are proposing a different EHR, not just meaning a different instance of an EHR, but a different EHR entirely. So in other words, if a provider is on Epic 9.5, they could not exchange with or send a summary of care document to another provider on Epic 9.5 and have that count as one of these electronic transmissions. They would have to find somebody who is, for example, on McKesson, somebody who is on a completely different EHR platform. And as we discuss in the proposed rule, and there's quite a lengthy discussion of this, I encourage people to take a look at it. The idea here really to be moving beyond closed networks of information exchange. Number 16, we did move most of the public health reporting objectives from menu to core, immunization data to an immunization registry. Now we're talking about successful ongoing transmission. Obviously, stage 1 was just a test. Stage 2 is successful ongoing transmission. We did leave syndromic surveillance for EPs in the menu section. We moved it to core for hospitals, but we are leaving it in menu for the proposed for stage 2 EPs. Because there are not a lot of syndromic surveillance databases available at this point for EPs. So until that becomes a little bit more mature, we propose to leave that in the menu. And then finally, number 17, we continue with the privacy and security as a objective in the core for both EPs and for hospitals. You'll see in numbers 1, 2, 4, and 5. Those are new objectives within the Stage 2 menu for EPs. Again, there are 5 total, and an EP would choose 3 of these. We are moving a little bit from a little bit different structure for menu than we had in Stage 1. In Stage 1, if you'll recall, we had something of a deferral concept with the idea that menu objectives would move to core. Anybody who chose not to do a particular objective for stage 1 in the menu was essentially deferring it until the next stage. That turns out to have been a very difficult concept for people to have grasped, and so now we're moving to a straight selection process. It was also possible in stage 1 to select a menu objective that you could also be excluded from. So in other words, you could select a menu objective that you didn't have to actually report on, and we are moving away from that in the Stage 2 menu. So what we're proposing is a straight selection process, and that if you claim an exclusion for one of the menu objectives that you select, it's because there are a number of them that you would be excluded from. We don't want anybody to be excluded from meaningful use simply because they can't report So incorporating imaging results that are accessible through certified EHR technology is one for both hospitals and for EPs that we've proposed. It's important to note that the imaging result doesn't have to be incorporated into the certified EHR technology, although it could be. Having it accessible through the certified EHR, so in other words, a link in the EHR that would take you into another system that has it would be acceptable for this. Recording family health history for more than 20%, and then the last two are for successful ongoing transmission to a cancer registry or to another specialized registry. I won't go through the hospital core in as much detail because you'll notice that they are very similar. CPOE recording, the different recording objectives, clinical decision support incorporating lab results. A new one for hospitals that we are proposing in the core is electronic medication administration recording. It's essentially EMR tracking of medication orders, that it is implemented and used for more than 10% of medication orders in the hospital. The online access also for hospitals, and again, the idea that hospitals would encourage patients to use that online access, so there's a second measure there of more than 10% of patients actually accessing their information online. You'll see in 13, 14, and 15, we do move all of the public health agency reporting for hospitals to the core, and again, 12 summary of care transitions, similar to what you see with the EPs, with 10% of those being sent outside to a provider without an organizational affiliation on a different EHR. And finally, in 16, the privacy and security objective in stage 1. You'll recognize most of these menu objectives for hospitals from stage 1 or from what we saw with the EPs. Number 1 is the advanced directives. Although this was a menu objective for stage 1, we actually elected to leave this as a menu objective rather than carrying it over to core for stage 2. And partially this is because of the feedback that we have gotten about the legality of advanced directives, either including them or acting upon them within an EHR in various, according to various state and local laws and regulations. So until there's some decision about how that works, we've elected to leave that as a menu for most hospitals. Imaging results accessible through certified EHR, recording family health history, and a new one for hospitals that we're proposing is e-prescribing for more than 10% of discharge prescriptions. There are some changes proposed to stage 1. For some of you will know some of these different objectives and will understand some of this. For others, I would encourage you to take a look at the NPRM. We go into a little bit more of an explanation about these. Most of these are optional in 2013, but they'd be required in 2014. And this is because the certified EHR won't be certified to actually have this until 2014. And we didn't want to hold people responsible for any changes that we made beforehand that they might not necessarily be able to incorporate into their EHR reporting prior to getting an upgrade to the 2014 certification. So right now, the denominator for CPOE, computerized provider order entry, is unique patients with at least one medication in their medication list. There was a great deal of confusion about this among patients. Was it unique patients that had a medication list that was ordered during the reporting period? Was it just unique patients with a medication ordered by the particular EP? Neither of those things are true. It's not limited by the EP. It's not limited by the time period, but it proved to be very difficult for people to grasp, and there were even some vendors who had some issues with this. So we're proposing to move to a straight denominator of the number of orders during a reporting period, and then it would be the number of the numerator would be the number of orders using CPOE during the reporting period. Again, that'd be optional in 2013, required in 2014. For vital signs, we're proposing 2 changes. One of them is right now it is H2 for blood pressure and height, weight, and we're looking to split that into recording of blood pressure for H3 and above, and no age limit for height, weight. And then we are proposing to split the exclusion. Right now the exclusion is that for all 3 of those elements, if they are not relevant to scope of practice, a provider can be excluded from reporting on this particular objective. We have gotten significant feedback from different specialties that they may well record one or the other instead of just both. So we are proposing an exclusion for recording blood pressure or for recording height, weight, depending on your scope of practice. And again, that would be optional in 2013, but it would be required in 2014 as a change. We are moving away, as I said, from the test of an electronic transmission of key clinical information. We're proposing to remove that requirement effective in 2013. It's turned out for any number of reasons to be a difficult concept for people to grasp, especially for an objective that really was a test. It didn't even have to be a successful test. It just had to be a test. But as we move towards the more robust health information exchange objective of summary of care, we're looking ahead to that, and we're going to leave the test of health information exchange behind. As I said, we're moving away from the idea of an e-copy of health information upon request, and we're moving towards the ability of patients to access that information online. So therefore, these two objectives, one of which is core, the e-copy of health information, one of which is menu right now, which is electronic access to health information. We'd be proposing one objective to replace those for stage one, and that would be providing the patients the ability to view online, download, and transmit their health information that's in line with the online access that you would have in the proposed stage two objective, but obviously stage one wouldn't include the measure of patients actually accessing it. Again, this wouldn't be required until 2014. And then finally, for public health objectives, we have had some feedback that there may be some local or state regulations that prohibit the upload of such information. So we are proposing, effective in 2013, the addition of except where prohibited. We certainly didn't want people to be caught in a sort of loophole where they were required to report and yet they could not report. I'm going to very broadly sketch out what clinical quality measures look like for 2014. The important thing to keep in mind here is that just as the certification of products will not have a stage one and stage two certification, they're going to have a current certification, which is 2011, and then they'll have a 2014 certification, which will allow them to do both stage one and stage two objectives. CQMs are going to work a similar way. There are the current structure of CQMs, which for EPs are the 3 core, 3 alternate core, 3 menu, or 15 total CQMs for hospitals. But in 2014, we'll move to a clinical quality measure structure that is the same for everybody, regardless of whether you are in stage one or stage two. So there are a couple of different things that are on the table. One of them is the notion of 12 clinical quality measures for EPs with a selection of 1 out of each of 6 domains. Again, please take a look at the NPRM because it will break down what those different domains are, but they basically line up with the national quality strategy that HHS has outlined about patient engagement, high priority conditions, so on and so forth. There's a separate possibility for a core of 11 clinical quality measures plus a selection of 1 menu measure from a variety of CQMs for eligible professionals. So please take a look at those and feedback. We are also looking at a PQRS option where essentially this is something of a deeming option. We're heading towards an idea of alignment with clinical quality measures so that you would report on the same type of clinical quality measures regardless of program, and so that you would have to report only once instead of reporting once for PQRS, once for EHR incentive program, once for ACO. The idea is to get us to a point where you're actually reporting once to CMS rather than separately for multiple programs. We may not be completely there with this, but we're getting closer, we think. And there are also some options for group reporting, which we'll talk about in just a second. We are moving to 24 CQMs for eligible hospitals with 1 from each of the domains I discussed before. There are some group reporting options. This is for Medicare only. For Medicaid, you're going to electronically report the clinical quality measures through your states. I would encourage people to take a look at these, but essentially we have the G-Pro option that we talked about before. This is the software that you would, if you're in the physician quality reporting program, you would be using this already, and you could use it for group reporting of CQMs. You could also, if you are already doing group reporting as part of an ACO, the Medicare Shared Savings Program, you could essentially report clinical quality measures through your ACO, and you would be deemed for EHR incentive reporting. And then finally, there's a separate reporting possibility where you could report as a group, and a group would just be any 2 EPs that are associated under the same TIN would be able to submit their clinical quality measures electronically as a group that way as well. So really trying to provide as much flexibility as possible for people to electronically report their clinical quality measures. There are some Medicaid changes that are proposed in this rule, and I'll let people look at the NPRM for detail, but essentially it's some expansions of the definition of a Medicaid patient encounter. This allows some expansion of patient volume calculation, and it gets a little bit weedy, but I would encourage people to take a look at it because it will give you a lot more information than we could probably cover right here. We're also enabling or proposing to enable the participation of 12 children's hospitals as part of this program that were inadvertently excluded simply because they didn't have a CMS certification number. CMS certification number is how CMS recognizes a hospital, but because these children's hospitals don't actually see any Medicare patients, they don't have a CCN, and we're just proposing to give them sort of a placeholder number to let them participate on the Medicaid side. One of the big areas that we do address in this rule is the proposal for Medicare payment adjustments. The payment adjustments are mandated by law to go into effect in 2015, and we lay out how those will be calculated along what time schedule. This graph here may not make a lot of sense at a first glance, but essentially it boils down to this. We need a period to look back to say that you were a meaningful user, and therefore you will not be assessed a payment adjustment. Keep in mind the payment adjustments are just for Medicare eligible professionals. They are not for Medicaid. There are no payment adjustments mandated on the Medicaid side. So essentially, if you were an EP or a hospital that demonstrated meaningful use in 2011 or 2012, and keep in mind that's calendar year for eligible professionals, fiscal year for hospitals, we're going to look back for your first full year EHR reporting period. So we'll look back to the first full year we have, and that'll be 2013. Remember, we're going to look at this in 2014 so that we can assess the penalty in 2015. So we have to look back for the latest full period. That's 2013. If you didn't demonstrate meaningful use until 2013, that's fine. We'll just look at it for a 90-day reporting period in 2013. Obviously, as we move forward, we're always going to keep looking for that latest full or 90-day reporting period. So we'll be looking in, for 2014, we'll be looking in 2016, or I'm sorry, for 2016, we'll be looking in 2014, 2017, we'll be looking in 2015, so on and so forth. If you were a very late comer to the program and you were not able to demonstrate meaningful use until 2014, when we first began looking for your meaningful use period, that's okay too. We just need to be able to see that you had a 90-day EHR reporting period sometime during that year. Because we need time to process your meaningful use and then process the fact that you had it for payment adjustments, we are proposing a shortened time period for you to be able to get those attestations in for 2014. So you're basically, if you're an EP, you have to attest no later than October 1st of 2014 for your 90-day reporting period, which means you couldn't begin it any later than July 2nd of that year. Hospitals, because they work on the fiscal year, would report or would attest no later than July 1st, 2014, which means they'd have to begin their 90-day reporting period no later than April 1st. We are proposing some categories for hardship exceptions. There are 3 categories that we are proposing. One of them is insufficient internet access. So if you're essentially in an area where you do not have broadband capability, there are a lot of robust information exchange objectives in here, and you would not be able to meet them if you didn't have sufficient internet access. Newly practicing EPs, if you are fresh out of residency, for example, and have never done any type of Medicare billing, you're not going to have any type of history with us. You wouldn't have been able to establish meaningful use. We didn't want you to come out of the gate and have a penalty assessed to you automatically because you don't have a look-back period. So we're basically giving you 2 years to get up and running and have a look-back period for meaningful use. Hospitals have a similar time limit on it, but they would only get a year, basically a full year cost reporting period for them to get their cost reports in. So we would, again, have something to look back at and say you've been a meaningful user. Critical access hospitals, same, work similarly. It would just be a year after they accept their first payment. And then finally, the third category is sort of a catch-all. It's for extreme circumstances. If there was a natural disaster, if you used a cloud-based certified EHR and that vendor went out of business, so you no longer had access to your cloud-based EHR, those type of things would be the type of thing that we would look at for a potential hardship exception. And finally, we are discussing another possible category for exceptions. We don't propose it, but we're asking for public comment on it. We do know that there are some specialties that face not just one, but a number of barriers that could pose a significant hardship in trying to meet meaningful use. One of them is the lack of control over the availability of their certified EHR. An example that we cite are radiologists, anesthesiologists, or pathologists who really don't have any control over what product they may use, who also don't necessarily interact directly with patients or don't have a need for follow-up care with patients. We're seeking comments on whether those three particular specialties or other particular specialties should have a category for hardship exception for Stage 2. And that is a very fast overview of the Stage 2 NPRM. There's obviously a great deal of more detail that is involved there, and I would encourage people to read through the actual rule and comment, again, not just on what you like, but also on the things that you don't like. So I'm going to hand this back, and we're going to take some question and answers.
So, Rob, that was fantastic. I mean, you really covered a lot very, very efficiently. There's so much detail there. We do have a lot of questions, so I'm just going to jump in. Some of these you've probably already touched on, but I want to just make sure we close the loop. So one is, do the clinical quality measures under meaningful use be integrated with PQRS so that meeting meaningful use will avoid payment adjustment in 2015 for meeting PQRS? I think you said yes to that, right?
Yes, it is. That is one of the many areas of alignment that we've tried to do. Not only have we tried to align the particular measures that are being reported between the two programs, and you'll see some of that as we move forward, but we're also trying to align reporting. So essentially, if you report through PQRS, you would be deemed as having reported your clinical quality measures for the EHR incentive programs.
That's
We're also
great.
working on a similar reporting method for hospitals, so that essentially for the inpatient quality reporting, we're proposing that there would be a way when you submit electronically, it would be deemed as meeting both.
That's great, very helpful. And then, so in the NPRM, I noticed that 10% of summary of care records has to be another certified EHR outside of your legal entity. Is that correct?
That is correct, and that is one of the major areas that we're seeking comments on. I think when we talk about it in the NPRM, we talk about trying to move information exchange beyond just closed networks, whether that's a closed organizational network or a closed vendor network, and be able to have robust health information exchange across a number of different providers.
Great. And now we have, so for providers who have been successful with meaningful use in 2011, are they required to do sort of an extra year at the end to collect the entire incentive, or will they still be done in 2016?
So if you are finished in 2000, or if you started rather in 2011, you're going to receive 5 years of continuous incentives, 11, 12, 13, 14, 15. But if you don't continue with meaningful use in 16, 17, 18, and so on, then you would be assessed a payment adjustment for Medicare claims. So obviously the way the program works is we begin with the incentive, and then after that comes sort of the payment adjustment. So sort of carrot and stick has been the way that Congress structured this particular incentive program.
So you're never done. You have to keep doing it.
That's correct.
Right?
That's correct. Meaningful use is becoming a part of the healthcare landscape.
Very good. So another question says, have to be 60% lab and 60% radiology each, or I guess both?
We discussed this specifically in the NPRM, and it's for each.
Okay, good. How can you, so on number 10 on your list of items, I think that was getting patients to access their information electronically, I think. How can you make 10% of your patients do so in point 10? I think that was what 10 was.
How can you make 10% of patients do so?
Yes.
That's one of those areas that I really, being in the public comment period, I can't really talk about the how to get there or intention or anything like that. I can just say that, you know, that was one of the measures for this particular objective that was proposed by the HIT Policy Committee. A lot of these objectives were substantially adapted from the recommendations of the HIT Policy Committee, and as I said, we talk a little bit in the NPRM about we think that providers are in the unique position of being able to encourage patients to take an active role in their health care, and that includes having them access their information online.
So next one, if our doctors met 2011 90-day attestation and received 2011 meaningful use payments, for 2012, will we need to meet the same requirements as we did in 2011, but now for the full year of 2012?
That is absolutely correct. That is exactly the way it works. You know, your first year of meaningful use is a step year, so you're really doing just 90 days of reporting. But from then on, meaningful use becomes an entire year is your reporting period. So 90 days of stage 1, a full year of stage 1, and then your next step is the stage 2 requirement. So you'll move on to a stage 2 for a year, stage 2 for a year, and then the next step would be stage 3.
So we have a couple others about, you know, how do we get our patients to access us if they don't have computer. I'm going to skip those since given what you said about, you know, not being able to really comment on those. If the rule, here's another one. If the rule changes to stage 2 take place as proposed, it appears that the practice could be penalized for patient. Oh, no, that's another one on that. I'm going to skip those. These about.
No, but I think that's a good point. We do draw attention to that in the stage 2 NPRM. Keep in mind that, you know, I think that last question introduced this great. This is a proposed rule. These are not the requirements that are set right now for stage 2. We're seeking public comments on these as proposed. And one of the areas we specifically call out for comment is where we have in several objectives patient actions being part of meaningful use.
And being that it's outside of the control. So we do see several sort of comments about that topic. Let's see. Can the 10% sent electronically be to a health system organization to be stored in the repository? So I think that is the sort of the HIE requirement, getting it to some other entity.
Yeah, and this is one of those, absolutely everybody should go and read this particular section of the NPRM because we have a robust discussion about the standards that would be used, and we do propose that, you know, if you sent to another provider through an exchange that is NHIN affiliated, this is the Nationwide Health Information Network, that would be one of the acceptable ways of transmitting.
So with regard to the summary of care document for more than 10% sent electronically, does this mean by fax, or if by email, is there any level of security or encryption required?
So specifically for summary of care, and when we talk about electronically, there's two separate components here. There's providing a summary of care transition, and one of the things that we say in the current stage 1 final rule is that if you have a reasonable expectation that the patient could be able to deliver that summary of care transition to the next provider, then it can be provided that way, which is why in stage 2 we're proposing this additional measure of 10% of them being sent electronically. When we talk about sending those things electronically, we're talking about true electronic exchange, and we have a discussion about the standards that would be used for that exchange. We talk about direct and a SOAP and some of the other standards that we are proposing for this. But it definitely is electronic exchange. It's not, a fax doesn't qualify for that. Sending an electronic file on physical media wouldn't qualify for this. It has to be an electronic exchange. And again, I encourage everybody to take a look at this section because we have a little bit more of a discussion about transport.
Does sending the CCD to a health information organization satisfy this requirement if the health information organization does not have a certified EHR?
There isn't a requirement for the transitions of care for the 65% that it has to be transmitted to a provider of care that has a certified EHR. That it could actually go to somebody who doesn't at all. Obviously the preference is somebody who has a certified EHR who's going to be able to take those documents in that standard and load it into their system. That's going to be the best way to use information. But we recognize that not everybody is going to have that, and so at that point it's really a paper copy of that summary of care would work in those 65% situations. But for the 10% of electronic exchange, it's going to have to be electronic exchange to a provider that has a different certified EHR. So at least 10% of those are going to have to go to somebody that has a certified EHR.
With the delay of stage 2 until 2014, will the EHR certifications be extended through the end of 2013?
Yes.
Currently, they expire in 2012.
Yes, I know a lot of people are very worried about that, but yes, they will. Steve Posnak's going to talk a little bit more about that. The certifications will be extended a little bit. The way that we collect clinical quality measures right now, we've got direct attestation through our website. There's also some EHR reporting pilots that people can participate in. Those methods will continue for 2013. That's why you will also, if you first attest in 2011, what you do for stage 1 will be continued until 2013. But in 2014, that's when everything will really take over. The new stage 2 requirements for people who are ready for them and the new certification of products with all of those capabilities and the new CQMs, clinical quality measures.
Are certified vendors then going to be obligated to provide a patient portal to attain certified status, meaning to be certified that they won't be able to sell the portal a la carte? Would it need to be an integrated part of their product?
So this is probably a better question for Steve Posnak, but I'll talk a little bit very briefly about it. We're moving away from the concept of a complete certified EHR. Those of you who know now, you can buy a certified EHR complete, or you can buy it modular, and then you can take all of the module components and sort of add them together until you get a complete EHR. A complete EHR, and there's no reason why you couldn't still buy something that does everything in the world, but it allows you to do everything, even the menu objectives that you haven't particularly chosen for stage 1. Moving to 2014, you're not going to be required to have EHR technology for everything, just on the objectives that you're actually going to meet. So in a way, although there will be some core functionality that all EHRs have, what ONC is calling a base EHR, you're sort of switching to more of a modular approach in 2014. So yes, there will be a certified functionality for an online portal. If you were to purchase an EHR that did everything under the sun, it would include that functionality. However, most people are probably going to get there through something of an a la carte selection of EHR products.
Is the patient portal requirement for the EHR for meaningful use stage 2 applicable to Medicare, Medicaid, or both?
Both. The way that meaningful use works is that the requirements for meaningful use are the same regardless of Medicare or Medicaid. So this would be a requirement on the Medicaid side as well.
So what if your referral network external to your facility or your practice happens to use the same EHR that you do? Do you need to find someone else to refer to just because the rule requires it?
We have a discussion specifically about this possibility in the Stage 2 NPRM. We're seeking public comment specifically on it. So I would say that if there are folks that are concerned that a requirement like that would make it difficult to meet meaningful use, that's the type of feedback to hear.
Would a patient's preference to use their own PHR for access to the clinical summary and/or secure message with their EPs be a disadvantage for the EP meeting their objectives for meaningful use stage 2?
I'm not sure how fully I can answer the question. What I can tell you is that when you meet the objectives for meaningful use, you have to meet them using the capabilities of your certified EHR. So you're going to have certified software that provides that online access. If your PHR isn't certified, then you wouldn't be able to provide it in that way under this proposed rule.
Is the image result the actual image or the dictated radiology report from the radiologist?
Again, please do take a look at the rule because we have a little bit of a discussion about this as well. But what we're talking about is accessing image results, and we're talking about having them be accessible through the EHR. So it may not even be the image result that is accessible in the EHR. It may be a link to the image result in another non-certified imaging system. It's just the ability to get to it through the EHR.
Let's see this one. So in regards to number 1, can the patient be sent electronic message to say that their information is available from an off-site facility? For example, send a patient for an MRI who is off-site and they have their own electronic data transmission. Would that satisfy, and giving them access to the records from that imaging facility?
So again, this goes back to the concept of meeting objectives using certified EHR technology. Every objective has to be met using that certified technology, and if you're using something else, then you're not using certified EHR technology. That said, I think that when we get to the point where we're sort of asking questions about, well, would this circumstance meet the objective? Would this circumstance? You got to keep in mind that we are still in the rulemaking process. We are still in a proposed stage. These aren't set in stone yet, and nobody can answer what will definitely meet and what will definitely not meet the requirements for these different measures. That's the type of feedback that somebody could give in a public comment.
Is family health history to be codified to a standard?
There is an associated standard to it, and I would say that you would probably have to take a look at the ONC rule. Our rule really deals with the meaningful use aspect of it. The particular standard that your vendor will be required to use or your EHR will be required to store information in is detailed more on the ONC side, and I can't give you a huge discussion about it right here.
If our eligible providers begin and register in 2014, do we follow stage 2 requirements or do we start with stage 1?
That's a great question. We get this question a lot, and that's part of what that chart that I showed early on is all about. You always begin your first year of meaningful use in stage 1. You're always going to do your first year of meaningful use 90 days in stage 1, and then your second year will be a full year of stage 1. Your third year would be a full year of stage 2. So nobody is going to do stage 2 until they've done 90 days and a full year of stage 1.
Do you know if the plan is to move the stage 2 menu items into core for stage 3? We
do have something of a discussion of this in the NPRM. We have proposed the core menu structure in stage 1 and indicated that as we move forward with stages, the idea is really to move menu items into core. Obviously, to do that, we'd have to look at applicability across a pretty wide range of providers. But as you'll see, as you look at both core and menu objectives, there are proposed exclusions for most of these for providers who wouldn't be able to report on particular objectives.
Is the co-reporting of meaningful use and PQRS available in 2012 or 2013, or will it begin in 2014?
It will not be available in 2012 or 2013. We do have a EHR reporting pilot that providers can participate in, and we are extending that pilot through 2013. We would be thinking in terms of the, as we propose in the rule, the PQRS as an electronic reporting system in 2014 and beyond.
So we're going to have to let that be the last word. We're out of time. Robert, thank you so much for a really very informative presentation and a great Q&A. Thank you all for joining us today, and we are going to do the same program again next week. So again, thank you, Robert, and thank you all for joining us. Now, when you log out, we are going to, you're actually going to have a quick survey pop up on your screen. Please do fill it out. It's just 3 short questions, and we really do use your feedback, so please just take a moment. And then we do hope you'll join us again this Friday for the program on standards and certification. So thank you all very much.